So we're going to go ahead and get started. We've got quite a full schedule today. I just want to let everybody know that there will be no meeting next month. For July, the Leadership Council will have next month. Did I say July? Yeah. Excuse me, June. There'll be no Leadership Council for June. As well, there will be no Leadership Council meeting in December as well. So, right, because of the opiate summit that's happening with Pacific Northwest University in Yakima. That, by the way, that will be happening on the 19th, 20th, and 21st. So if you're able to attend that, and I'm sure Diane will talk more about that, please contact us for more information about how to register. I think so far, how many people have we registered for that?
There's over 100 now.
There's over 100 people registered, and there's more than a month to go. So the spots for that summit are filling up quite quickly. So let's go through and do introductions, and I am going to start with Susan up at the top.
I'm Susan Campbell. I think it's and volunteer at the Amy Person, I'm the health officer for West Franklin and Pacific County.
Okay, health officer for Roll and Columbia. And John Barr, deputy chief, Pasco Fire.
Wonderful. Thank you, Shauna. Hey, Marcy.
Donna Albuquerque, Regional Director of Operations for CACH.
Fantastic.
We're doing very well in community health. There's no way I can remember this. There's one American. That was your.
Both community services. Right. Fantastic.
Hey, Val, I'm Val.
Perfect, Penny.
Those only Catholic generic.
Trustee Cole, Greater Columbia Central Community College. Rachel Guest, Greater Columbia ACH.
That's just Greater Columbia.
Leanne Turnbull, ACH. Carol Winter, Greater Columbia ACH. Diane Halo, Greater Columbia ACH. Jenna Shelton, Greater Columbia ACH.
Rhonda Hoff, Yakima Neighborhood Health Services. Jocelyn Pedrosa, Yakima Neighborhood Health Services.
Good morning, I'm Lisa Hefner from Yakima Neighborhood Health as well. Michelle Sullivan, Yakima Neighborhood Health Services.
Fantastic. And on the phone, if we could go through and make introductions for people who are listening on the phone.
Sierra Foster from Astria.
Thanks, Sierra.
Berta Lopez from Virginia Maine Memorial.
Thank you.
Holly
Evan
Seiler.
Marcus, Death Valley Health.
Let's start with Holly.
Holly Seiler, Second Harvest. Liz Rice, Tri-City Community Health.
Richard Lee, Tri-City Community Health.
Richard Lee. Anybody else?
Kirk Williamson, Ben Franklin Community Health Alliance.
Kirk, thanks. And who was behind Kirk?
Samantha Frederick, Quality Behavioral Health.
And Jack Davies, Northwest Rural Health Network.
Thanks, Jack.
This is Courtney Ward with Mayor Group.
Thank you, Courtney.
Marcia
Joe
Baden,
Ketterer,
Garfield County
Astria Health.
Hospital.
Marcy, let's start with you.
Marcia Baden, Garfield County Hospital District.
Thanks, Marcia.
Joe Ketterer, Astria Health. Good morning.
Good morning. Was there anybody else?
Teresa Kim and TJ from Police Medical and Pullman.
Fantastic. Thank you.
Chuck Eaton.
Good morning, Chuck. So if you're attending on the phone and you're a practice transformation organization participating in our practice transformation efforts. If you would please type your organization name in. As you register, we can account for you for meeting milestone deliverables. Is there anybody else on the phone? Oh. Ashley, want to introduce yourself?
Hi, I'm Ashley Fernandez with Greater Columbia.
Lauren Johnson with Greater Columbia.
Fantastic. Thank you all. So next, we're going to go through the GCACH report. And I think we'll try to get through this pretty quickly here. Jenna, did you want to say something about practice transformation success stories?
Yes, I think Martine is up for PPD. Oh. Martine. You need to take the microphone.
So, this month, like every month, we do stories about spotlighting different organizations that we are working with for practice transformation. I mean, in the past, I wrote about Columbia Health Systems. This time around, I wrote about CGHA, Columbia Basin Health Association, which for them, they only have one clinic in our region, which is Clinell. And through the reporting workbook, they were able to identify some areas that they needed more improvement on, and areas that they are working towards improving. You know, they see a lot of patients, and they are working on their empanelment. They're doing other things, self-management tools they're implementing. So, you know, through this process, it was really nice to see those organizations identifying, you know, areas that they would have possibly maybe not been able to identify, or if they have, maybe longer into the future. So it's good to have those areas, you know, kind of popping out at you, you know, this time around. So good job, Columbia County Health, or Columbia Basin Health Association, and David Sackett, which she has been the main point of contact for practice transformation. Okay.
We also want to spotlight Chad Health, which is great that Donna's here. Chad has done a really amazing job because they're actually in Lewiston and Clarkson, so Idaho and Washington, and we've been working with them with their dental site specifically, and they really could have just said, like, this doesn't apply to us. What do you even mean practice transformation? We're a standalone dental site. But they really worked hard to integrate bidirectional integration, and they have been doing PHQ2, which is an assessment that shows potentially if a patient might need behavioral health services, and we've only done quarter one, and as of the beginning of quarter two, which we're in right now, I know at least one patient has been identified and referred to behavioral health services. And also they've hired a community health worker, which has been awesome because they get to do outreach to their patients who've been in the ED. They're even like looking at diagnosis to see if they had anything to do with dental work. And so this also being able to be spread to their Lewiston clinic in Idaho. So the work is getting scaled out, which is exactly what we want for practice transformation. So great job, Chad. Thank you.
It's wonderful to hear all those stories. Becky, you want to talk about the financial executive portal?
Thank you. Good morning, everybody. So most of the payments that came for this last month have been for the completion of the Q1, as the navigators were just talking about. So congratulations to all of you, really. You've all been working really hard, and we've got just about everybody completed all the milestones. So we paid out $658,000 to providers to finish their Q1. And then we also paid the Community Foundation for the administrator agreements that we have with them to address the social determinants of health that were identified in their community. So total for 2019, $7 million. Yay. So thank you, everybody. Oh, yeah, the portal's closed for a month. Thank you, Rachel.
So a real brief update to the CSI reporting portal. I've given some updates in the past, and we're happy to announce that as of yesterday, the web reporting tool is now online, and our practice transformation navigation team is going through it and doing some debugging and troubleshooting. They're looking at each of the milestones, the questions, they're putting in data, they're testing it out. We've already come up with a number of issues, and we'll be giving a report back to CSI as those things arise to try to get those issues resolved. Once we've gone through that, we hope to go through a trial test with one of our practice transformation organizations to see what their input and feedback is on the tool. I will tell you from what we've seen from the demonstration, it looks really, really nice. It has automated features. So for the subsequent quarter to a reporting quarter, when an organization goes in to report their results, we're going to have the reportal put up the previous quarter results so that an organization doesn't have to go back in and needlessly enter the same data over and over and over again. So we're trying to make this as streamlined and as easy as possible for the organizations that will be submitting information through the portal. Carol, or actually Ruben is gone, so do you want to talk about the practice transformation quarter one reporting?
So you might wonder why all of this emphasis on reporting, and well, it's because that's how Greater Columbia ACH gets paid. So we get incentive dollars that then we can pass forward to our providers. So we place great value on those reports. And what didn't mention is that the reporting toolkit is many, many pages long with many, many options. And so the web form is to streamline the reporting for all of our providers. It's much simpler. But in the meantime, we did review the first quarter results with our practice transformation work group. And this is part of their charter to look at the results of what's happening, to evaluate. It's part of our quality improvement strategy. Plan, do, study, act. Is this working? What do we need to tweak? I think what the most interesting thing was regarding that meeting was that we talked about the barriers that we were having, or some of the providers were having. And when we understand those barriers and those challenges, then we can accommodate those. We can flex. We can, provide more resources. We can provide more support. So really, the quarter one report really just provided us a snapshot of how well our toolkit is working, how well the reporting is working, and it's going really well. Unfortunately, your report that you have in front of you is in black and white, but you can see the progress that all of are making, and we're just really excited that we're moving down the path of practice transformation. Thank you.
Thank you, Carol. I just want to call out that Martine gave a real nice presentation that outlined the summary results from the organization during that meeting. And by the way, this is a very transparent process. If individuals are interested in seeing and hearing that meeting, we have it recorded, and that information is available online if people want to go back and listen to that meeting recording. So next, we're going to talk about the Opioid Crisis Summit that's happening here in June.
So just a reminder that the Opioid and Trauma Informed Summit is going to be the 20th and the 21st. The 19th is actually a community night. It's going to be at Eisenhower, and it's open to the community. So it'll be a good way to address the issue with some of the high school students and parents and grandparents or whoever wants to attend that evening. Anyway, so make sure you guys are registered. We're hoping to do some targeted marketing for this and advertising. So we really want you guys to get in there and register. That way you have a spot. Anyways, if you have any questions, you can reach out to me or We have it on the website. There's all kinds of information on the website as well, and I can send you that link. And I believe it's in this document? No, it's in last month's document. But I can, if you need the website, you can click on it on the electronic version.
So a lot of work is going into this summit. Diane has been on the PNWU website. There's a whole page devoted to the summit. The speakers, their biographies are there. The schedule for the summit is there. There's a lot of information as well as the registration. As we've talked about, we're real excited about the speakers who are going to be there. As we mentioned, Dr. Vincent Folletti, who was one of the original researchers for ACEs, will be one of the keynote speakers for the summit. We're very excited about that. Also, if organizations want to do sponsorships, there are sponsorships that are available to participate in, as well as the individual registration. And again, as mentioned before, for providers, I believe it's for DOs and MDs. If you want continuing medical education credits, those are available through the summit as well. And I think the last two things here are from Lauren.
So I'll skip the article about just the meeting today, just because you're all here. You'll be able to see what that's about. But the second article is to highlight sponsorship for this quarter, which went to Chaplaincy Healthcare's End of Life Conference. We gave them $3,500 for their conference at I believe it's scheduled October 18th. And just a reminder that our sponsorship application opens every quarter. We're always looking for more events to sponsor, more outreach. So if you're interested, I have our link up there to our application and our policy for more information.
Thank you, Lauren. So the next thing that we're going to do, jumping ahead to the July meeting, as last year, we had a leadership council meeting that was focused on workforce. And we hope to repeat that again this year in 2 months' time. To get ready for that, we'd like to survey our council members by asking them some questions relating to workforce. So if you look up here on the screen, you will see the website that if you have a smartphone that has internet access, we'd like you to go to it. On the phone, if you cannot see this, it's M as in Mary, ENTI.com, menti.com. And once you're there, the user code is 233934. Menti.com, and the user code is 233934. And the question is, what employment positions are most in demand within your organization right now? So what sort of jobs are you posting for that are in most demand? We're starting to see some familiar positions come up. So while you're entering in that information, we're going to collect that and bring that back to the group at our July meeting to report on what you've told us. And there's a second question, which we're going to jump to. And that second question, what employment positions will be most in demand in 2021? So based on what's going on in healthcare with value-based payment, practice transformation, some of the other trends that are going on in the marketplace, what do you expect your employment needs will be like in 2021, so 2 years from now? Okay, thank you very much for your participation in that survey. That's valuable information to us as we go through the planning process for that meeting coming up. We're still trying to line up speakers who will be presented, and as that gets put together, more information will be sent out to you. So for the next item here, we're going to talk about some data. As you know, in the last few Leadership Council meetings with Patrick in this place, he has talked about the Community Trends Report, which is a wonderful, valuable website with lots of different data points tied to particular domain areas. Today, we're going to look at another website. This is the Healthcare Authority website. And I'm going to show you some of the information that's available on there. I'm only going to touch upon one of the dashboards that's on the Healthcare Authority website and only a couple of the dashboards within that particular tool. So I'm going to change places with Lauren. And I apologize, I have to turn my back to you as I manipulate the keyboard here. So to get out this information, what we need to do is go to Healthcare Authority, and if you want, you can type in the full name, Washington State Healthcare Authority, and healthcare is 2 words, but what I typically do is I just type in WAHCA, and the very first thing that typically comes up is the Healthcare Authority website. It looks like this. This is their updated front page, and so we go to the search area, and we simply type in dashboards. And the very first result here is what's called data dashboards. So we click on that, and this is a page within the Healthier Washington section of the HCA website. So scrolling down here, the page that we're going to look at is the ARM, which is the Analytics Research and Measurement Division of Healthcare Authority, which is actually a cross-functional team of analysts. But I also want to point out a couple of other things on here, which we'll try to return to in future meetings. There's the Healthier Washington Measures Dashboard. And down below here, there's a bunch of other dashboards, including the Washington Health Alliance Community Checkup, HCA has a bunch of data reports that relate to enrollment by MCO and by geographic area and more. DSHS has their community risk profiles, including for the ACHs, although I will tell you that the data in there is a little bit old now. There's also the Department of Health Washington Tracking Network, which is a very valuable mapping site that looks at social determinants of health and healthcare information. And then OFM has their Washington Healthcare Compare website that can compare service, cost, and quality across different regions and different providers. And that's one that I'd very much like to come to at a future meeting. But for today, what we're going to do is go into the ARN dashboard. It takes a minute to load. And the site looks like this. So each one of these large symbols is an icon that we can press upon to produce a report. Again, in a future meeting, we can come back to the opioid use dashboard, which has quite a bit of information about prescribing behavior for buprenorphine and for some other things. But for today, we're going to look at the emergency room, the inpatient, and possibly the Medicaid Explore dashboard if we have time. So we're going to start off with the emergency room. And as we've talked about several times now, emergency room utilization is a key concern for us. So this page looks at all the hospitals in Washington State for utilization by Medicaid members. However, this excludes dual eligibles, those individuals who have both Medicaid and Medicare. And what it does is it sorts by the utilization in terms of visits and unique members with visits. And unique members with visits means that some of the individuals in this box may have received more than one ED visit. So we know that the ACH has the highest emergency department utilization, and accordingly, the two top hospitals in the state of Washington are Virginia Mason Memorial Hospital and Cadillac Medical Center. So, sorted by visits, we can see that Yakima Valley Memorial Hospital had over 41,000 visits. This is for 2018. Cadillac Medical Center had about 40,000 visits for that same year. Now, you can sort by member ACH, by member county, and by provider county. And I should explain here, when you sort by member county, you're sorting by where that member resides. So we're looking at utilization when we sort through that area in terms of the county of residence. So it would exclude utilization by members who reside from outside of that particular county. When we sort by provider county, that's all the utilization that occurred within that county, regardless of the Medicaid member residence. So over here on the right-hand side, you can also see that we have a distribution of utilization by male-female, as well as by age and by race and ethnicity. So just to show you a few things here in terms of tools, if we want, we can come here, turn off all these buttons. It takes a second to reset, and then we click on Greater Columbia ACH. And so now we're looking at hospitals that reside within the ACH. Now, some hospitals here have suppressed numbers, and that indicates where the member count, so again, this is where the individual resides, so you'll see some hospitals here that are clearly outside of the ACH, but when it says suppressed, it means that the member count for that particular hospital was less than 10. And as a general rule, healthcare authority does not display results to the public for member counts less than 10 for privacy concerns. So we can sort through the ACH. We can also come over here to the right-hand side. And in this tool, if we click on detailed diagnosis, what it does is it looks for the entire ACH, and it sorts by diagnosis across all hospitals that saw Medicaid members. As well, we can go to diagnostic class, which is a bit of a higher roll-up. You can see here injury, which is typically the #1 emergency department visit type is #1 here, and we can get the count for the Greater Columbia ACH. So for 2018, for our ACH, the number of individuals who went to the emergency room for injury in that general classification were 30,385. Now, let's say that we want to stratify that, this ranking by male and female. If we click on female here, you can see that those numbers are reduced because we're looking at just females. So this is really an amazing tool. I mean, for me, I get excited when I see data, but this is a great way to stratify different hospitals within a region to understand the reasoning for members going into the hospital for emergency department visits. Again, it's a great concern for us. To be honest, if we had more resources, we would take these numbers and convert them to rates and compare against hospitals across the state as well as the statewide average. But in itself, it provides some information to people who are doing research and exploration. So we can come back here and turn off female by clicking on it again. And let's say we wanted to look for youth, 0 to 17, click on that. And again, we can see that the numbers have decreased from the overall rate, but you can still see that there's quite a few individuals that come into the ED for injury, which again is probably no surprise. So we'll click on that again. Now, we can also, let me go back to the main page here.
And when it says it breaks down the injury, like what type of injury it is?
No, there are two ways to stratify that. That was the broader class. There is more detailed stratification of diagnosis too. And it might actually have some subcategories for injury in that. So looking at this, we can see Yakima Valley Memorial Hospital. If we do a right mouse click, or excuse me, a left mouse click on it, it'll open up a little dialog box here, whereas if we wanted to go through and look at just this hospital or exclude this hospital, we could do that. So it has some filtering technology. Now, if I click on this plus sign here, it opens up each hospital. So we can see again the detailed diagnosis categories, which for Yakima Valley, Virginia Mason Memorial, are other respiratory infections, and if we scroll down, we'll see Cadillac come up next, which is right there. And beneath that, there's more. We can also sort this by the hospitals. If we hover here, you'll see that, and that'll turn the sort into alphabetical ascending. And then if we click on it again, it's descending. And we can do the same thing here for sorting as well.
Well, this is Susan. I can't tell, but can you sort by dental or behavioral health as well as medical? Can, like, if you wanted to do dental emergency room in the GCACH region? It's probably one of the diagnoses. Is it on that?
So let's take a look here. This is the detailed diagnosis categories. Sure. So there's disorders of teeth and jaw right here. And so that's probably a broad category of dental. And again, if we wanted to look for youth, which is an area that we've looked at before, we could go to 0 to 17 to compare that number across the different hospitals, either within the ACH or across the state. There's also the ability to sort this by county as well. So there's a lot of nice filtering technology here.
If you click on the diagnosis, can you click on the diagnosis at all?
So doing that, again, allows us to exclude or include it in terms of the sorting. Any other questions about that? It's a great tool. Going back, so you were asking about dental, and there actually is a dental services utilization dashboard that is in progress right now. The ARM team is working on the development of that, and that has not come together yet. There's also a primary care services utilization dashboard that's coming forward in the future as well. Real quickly, I'll go to the inpatient facility one. This looks a lot like the emergency department. We have the same hospitals, but in this case, rather than looking at emergency department utilization, we're instead looking at unique members with admissions and the number of admissions. And again, there's the ability to sort and filter this by gender, by age, by race, ethnicity, by county, by ACH, by broad diagnosis, and by narrow diagnosis.
Look at GCACH.
So here we turn off all the buttons, and then we click on Greater Columbia ACH. And so because we have not filtered over here, this is going to include all members regardless of where they reside. So if people come in from outside the ACH, their numbers would be included in here as well. And if we click to open this, you can see, and if you've looked at hospital utilization like I have, I can tell you that the number one admission is typically newborn, vaginal, and cesarean, if there's an obstetric capability within the office, within the hospital.
I have a question for you, Wes.
Yeah, Penny.
Is there any data that shows, because this is all Medicaid data, is there any comparison to commercial folks and what the difference in utilization is?
That's a great question. There is a tool that's available, although to get into it, you have to have a license, and it's called the All Payers Claims Database. The All Payers Claims Database was put into existence through legislative law. And that database includes Medicaid, Medicare, and it includes commercial that doesn't fall under what's called ERISA. And ERISA covers those large employers that are self-insured. So essentially they take on financial risk themselves for their claims liability. So those individuals are excluded, but if for non-ERISA employers, commercial information is actually available in the APCD. But to get into it, you have to have a license to be able to access that information. And actually, this ACH is contracted with Public Health King County, Seattle, to get out APC data. So as we go through that process, if there are some specific reports that we would like to look at that might be in the APCD, we can talk about that as a group and see if we can get some of that reporting. But in terms of this database, because this comes from Healthcare Authority has information on, of course, Medicaid, which is their biggest group, but they also have what's called the PEB group, the Public Employee Benefits Board, and either now or soon to be what's called the SEB, which is the state employee, which is essentially teachers. So that information, I'm assuming at some point will come into these dashboards, but commercial is not rolled into this. So one other thing I want to look at so we can move forward is the Medicaid Explorer tool. And it looks like a lot like the Healthier Washington dashboard, which I think we've talked about before and we may return to in the future. But this simply looks at the utilization across ACH, across county, and it stratifies it by gender, by age, ACH, as well as the county breakdown. And there's a density map here that shows statistics, and if you click on one, and it's not going to update it there. So we have to update it here, so we'll turn this off. And let's focus on Franklin County, which is where we are situated at this minute. And the dashboard will update. And you can see here that these are the numbers for both female and male for Franklin County. So in Franklin County, there are 17,332 male individuals who fall under Medicaid, excluding duals. And the counterpart for female is 19,577, as well as a breakdown by age. So again, if you're very ambitious and you love to analyze data, you can take this data set, make it your denominator, take the data that we just looked at for either ED or inpatient, turn that into numerators, and then you could come up with some rates to look at this ACH or this county or the state and make comparisons.
Do you know if, on the ED data, if they plan to have it be able to be broken down by appropriate versus inappropriate use, or if that's something that our sites would have to like look at themselves?
I haven't heard anything about that. So the question is, there are some, I think it was, Susan I know knows this, when we were looking at emergency department data, was it California?
Yeah.
So they had come up with categorizations of what was considered inappropriate versus appropriate ED utilization. But I don't think that they've incorporated that here.
It's very complex algorithm for that process. There's New York and California that are both working on that system. And you can come up with whether a case is appropriate for the ED or for inpatient admissions as well, based on those algorithms.
So Bill said that for California and New York, they've come up with classifications for both emergency department and inpatient to separate inappropriate from appropriate type care. Dr. Person, did you have a question?
Well, I would say the challenge with that too is sort of separating kind of presenting versus final diagnosis. So if, someone's got a clinical with a fever of 103, that actually isn't appropriate ER use, even if they're suddenly diagnosed with an upper respiratory infection, and that's the final code, then that would read as inappropriate use of the emergency room. So I think they do need to be, you do have to be a little cautious in how you interpret a lot of this data, make sure that it isn't just looking at your discharge diagnosis versus your presenting complaints, because I think then it's oversimplified what happens.
So the comment is that we have to be careful when we start to dissect that data, separating admission ED data versus discharge ED data, and subtleties in the patient's profile when they come in, which might not be picked up through claims information. Because obviously, healthcare authority uses claims information from the MCOs to be able to stratify and profile this data.
So the question then, for this, most of this information would be coming from the discharge diagnosis, wouldn't it, since it's claims data?
I'm assuming it is, Rhonda. I'm assuming it would be. Because I think that, and Bill, you might know this, I mean, that would be the billable diagnosis, wouldn't it be the discharge? Yeah. Any other questions or thought about this information? Again, it's a great repository of information that's public and online and easily accessible. So again, hca.wa.gov is the website, or just go to WA-HCA at Google. Search for data dashboards or dashboards, and then that page will come up, and it's the ARM dashboard. Martin, did you have a question?
Yes. So if you click, how you click on child 0 to 17, if you want to break it down by gender, is it able to do that?
Can you click on male?
No, it won't allow us to do some cross-cutting of filtering. Okay, thank you very much, everybody. So up next, we have heard a lot about the accountable communities of health and what's called Initiative 1, which is a major significant part of the DSRIP, the Delivery System Reform and Improvement Program. But there are other initiatives that are in place as well. There's an Initiative 2 that relates to long-term services and support. And we also have Initiative 3 that relates to foundational community supports around housing and employment. So this is something that we've been aware of, but we wanted to get more information. So we've asked some outside experts to come in who are participating in both of those initiatives. And first up, we have Leanne Turnbull from Southeast Washington Aging and Long-Term Care. And she's going to talk to us today about long-term services and supports.
Can you guys hear me, or will it record if I don't use the microphone? You need to use the microphone. Sorry. Not a microphone expert. Microphone shy. So good morning. Thank you for inviting me here. Our program manager at Southeast Washington Aging and Long-Term Care is Corey Blythe, and she sends her apologies and has asked me to come and speak about Initiative 2. I don't know about being the expert. I'm not involved in state policy or the metrics, so if you have questions in those areas, I'll be happy to take them back to someone who can give you more clear answers. What I do is I manage a department called the Aging and Disability Resource Center. Carol kindly passed out some cards about that. In the Resource Center, it's just one of the departments that we have in our AAA. That's the local area on aging, local area on aging for Southeast Washington. We cover 8 counties, and we have offices in Ellensburg, Yakima. The Kennewick office covers Benton and Franklin counties. We have an office in Walla Walla, Dayton, Clarkson, and Pomeroy. So there's other AAAs across the state. You may or may not be familiar with AAAs. I don't know when. Okay. And almost all are participating in Initiative 2. And some participate at different levels. We're going to talk about what we're participating in our 8 counties. And it is working. So you folks are very familiar with Initiative 1. That's your specialty. Initiative 2 is the service options that enable older adults to stay in their home or at least delay that placement and the use of higher costing Medicaid funds. And then there'll be someone else speaking to Initiative 3. So our Washington population is like that goes across the nation where the population of the aging is rapidly growing. And on this graph, you can tell by 2060, those over the age of 85 are going to have a significant impact on our health care. And, you know, truthfully, maybe not me, but that's going to include many of you. I haven't actually done the math in my head. I don't know if I'm still going to be alive in 26.
Not me.
What? So one of the things the Initiative 2 is addressing that's different from what I call traditional Medicaid long-term services support. This program actually wants to address those casual unpaid caregivers and giving that population support. So we're going to talk about numbers in a minute, but right now, 80% statewide provide care to their family, friends, or loved ones, and they're unpaid. And this just impacts them in so many ways in the families. They're spending their own money. It's preventing them from having higher incomes. It's depleting their resources. It may even prevent them from supporting their own children. And if they stopped providing that care, these unpaid caregivers, it has a tremendous impact to our Medicaid programs. So it's not just the life of the caregiver, it's social programs. So the goal of Initiative 2 was to provide and create a system that provides the right service at the right time by expanding person-centered choices. So in traditional Medicaid, this is the program you get. With Initiative 2, we want to offer more choices. And we're supporting unpaid family caregivers, totally different from traditional Medicaid, where the person who needs care is the complete focus. In Initiative 2, we've expanded that to include that casual unpaid caregiver. And the people who are at risk for institutionalization. So maybe we can prevent that higher costing institutionalization by keeping them at home longer. It's modeled after the Family Caregiver Support Program. This is Family Caregiver Support Program is an evidence-based program that wraps services around the caregiver so that they have the ability to continue that caregiving role while maintaining their physical, emotional, all the burdens that come along with being that caregiver. It's funny, I flip my paper and I forget to move the slide. I think we're on the same page. So one of the things that we found with providing these casual unpaid caregiver support is that if we can connect with them earlier, then we're going to be able to alleviate some of those stressors and burdens, such as depression, helping them with being comfortable with that caregiving role, and just the physical work that comes with being that caregiver that's performing that work. It's shown with the Family Caregiver Support Program statistically, your data person here, it significantly delays the use of Medicaid long-term services. And the caregiver's health is increased. Their well-being of these caregivers is increased. And the likelihood of them needing the long-term care is reduced. With the Family Caregiver Support Programs, it improves the outcomes for the family caregivers, and it's shown that majority of the caregivers, 84%, that's huge, show significant improvements. We're going to show a commercial at the end that talks about caregivers. One of the issues that we have with the Family Caregiver Support Program and Initiative 2 that we're tackling at the ground level is people who provide those services don't actually recognize themselves as caregivers. And so when I say the word caregivers, this is the first thing that you thought of was a professional that comes in the home and provides support. Because to the public, that's their first thought. Well, I'm not a caregiver because I don't work for a company that has that as a business. They just think of themselves as the person that's doing what they, in their marriage vows that they said through sickness and health. Or they're just helping their neighbor that isn't strong enough to get their garbage can taken off the curb. Or needs help getting their mail. And then maybe that turns into picking up groceries. And then I'm invested far enough to make sure that my neighbor is getting a meal every day. And then I'm taking them to a doctor's appointment. And this is great. This is communities taking care of each other, right? But what happens is, in my mind, as a neighbor, I might have some internal conflict because I didn't really think of that as my role as a neighbor. Or if I'm a daughter caring for my mother, my role was the daughter and my mother took care of me. And so I don't think of myself as a caregiver, but I am being a caregiver. So a lot of folks don't understand that. They just know they're getting stressed and they're just looking for something to help relieve that stress and they're unsure what that is. So the Family Caregiver Support Program actually surveys the thoughts and feelings of those casual unpaid caregivers about how they feel about the role that they have now. And we get many tears because most social service programs focus on the person who needs care. And it's not that we don't want to help out or provide services for that person that needs care, but we want to wrap services around that casual and paid caregiver to help them along that journey. And the Initiative 2 took some of those components out of the Family Caregiver Support Program and rolled them into Initiative 2. It's just tremendous.
I just wanted to thank you for being there for me. My mom had her multiple myeloma came back, and then she got a major brain injury that required surgery. So I was her caregiver for 2.5 years, and if you guys didn't have a caregiving program to come and run errands or clean house for me, that was a lifesaver for me, because you don't even realize, like, it does affect your job. It's hard to do your job, especially some of the head injuries, and then all the other programs that you're not going to be able to roll out. It's going to be a lifesaver for people.
And that's just one of the programs that we have that we can help connect people to. Either we're administering it directly out of the Aging and Disability Resource Center, or we're connecting people to their services, such as if they needed traditional long-term service support. And those are the kinds of stories that we hear all the time. If I'm caring for somebody and I don't actually need somebody to take over that job, I'm doing okay with that. But think about if you today had someone coming in 12 hours a week or 15 hours a week and doing your floors, or not a week, I'm sorry, a month, doing your floors and toilets, I could see that. But think about if you're caring for someone with dementia and your time is tied up with those daily tasks that you're trying to keep that person safe and fed, and clothed, and medical management. It's tremendous. So this is the nuts and bolts of Initiative 2. So the first one we call MAC, is the Medicaid Alternative Care. And these are for people already in certain programs with Apple Health Medicaid. And I won't try to do a big education on what those Medicaid programs are. There's a variety of Medicaid programs. MAC is specific to people being in a categorically needy or alternative benefit plan. That's what those acronyms mean. And I'm not a financial worker, so when people apply, the financial worker determines what programs people are in. The next program is the TSOA program. This is where we've seen our biggest growth. This is tailored supports for older adults, and we just, in our office, say MAC and TSOA. So this is not a Medicaid program that gives somebody a medical card like other Medicaid programs. This program has a limited benefit. It has a monthly budget. And so it's not for people who need 24-hour care or people that might need, 100 hours a month of care. It has to stay within the budget. But this is hoping to grab those caregivers and people that need care before they have the heavier needs. So one of the things that it does is it has a higher resource limit and a higher income limit than traditional Medicaid long-term service support. So say I have $50,000 in the bank. I'm not eligible for traditional Medicaid long-term service support, with the idea that those programs are asking me as a single person to spend my own funds, have a spend down, and then when I get to 2,000 or less, then I can apply to have in-home care. Well, if I own a home and my furnace breaks, how am I gonna, or my roof needs to be replaced? So many factors here, not just reaching a larger population with some higher resources and higher income, but it's trying to honor that, yes, we need some help. Maybe I just need help with babies. Maybe I just need some housekeeping and errands. I don't have to spend everything down. I can still maintain my home, and there's some other components that's different from traditional Medicaid long-term service supports. One of the components is the spousal impoverishment protections. And so they both allow the person to still maintain some resources. And so this, in part, is so that it doesn't impoverish the community spouse that's not on Medicaid.
Yeah, are you gonna, if you're gonna get to this, tell me, but are you gonna talk about for patients that also have Medicare, how those programs interact with that?
You know,
a lot of these folks are gonna have Medicaid and Medicare.
You know, Medicare's, how I explain it to people, it's health insurance
Right.
with different benefits. It doesn't have any in-home care that we're talking about in these programs.
Right.
So we would encourage them to see their doctors and utilize their Medicare benefits. We would, if there was durable medical equipment, we would try to have them pursue getting those equipment through their insurance. So
it doesn't affect it?
There's no effect.
Okay, that's great.
Yeah.
Thank you.
So traditional Medicaid, you're going to have to apply for Medicare, even if you've declined it previously when you turned 65. They're going to require you to apply for it. There's no requirement in this program.
We have a lot of our patients who are qualified Medicare beneficiaries. They're on QMB, so they're basically Medicare, but for the most part, Medicaid pays their premiums.
Right, and that doesn't give them a medical card.
Right.
It just helps offset those costs. And we do know about those programs, and we help guide people and help them with the applications, that type of thing.
So are they eligible for these services?
Yes, they are.
Okay, that was my question. Thank you.
It doesn't get them in the MAC program, but it gets them in the TSO program.
Okay.
So this is talking about the MAC. So they're already on some type of Medicaid Apple Health program that they're eligible for MAC. For both MAC and TSOA, they do have to be 55 or older. So traditional Medicaid, if you're getting in-home care, there's something called a state recovery. So that's where the state has the right to recover some of their Medicaid dollars. And this is waived during this demonstration for the MAC and TSOA program. So a lot of folks are like, I thought I was, I want my house for my kids. Now the kids might say, Mom, Dad, we want you to have care, but they won't go on traditional Medicaid because they don't want to lose their house. Even though Medicaid, estate recovery doesn't kick in until both spouses have passed, it's, again, it's a personal choice. So that's a really nice little hurdle we don't have to deal with this program. There's also no cost sharing. Traditional Medicaid, they look at your monthly income. If you're a single person, your income, I think the standard right now is $1,012 a month. You may have to contribute to part of your care. Now the financial worker is going to look at things like, do you have a Medicare supplement? They want to make sure you have enough to pay that. But if I'm making $1,700 a month, I don't have any other medical costs that I need to maintain, then my participation is right around $700 a month. I don't know about you, but $1,700 is really hard to live on. And to then have additional costs for my care, this is turning a lot of people away who need the care. So in this program, it's a much different benefit than traditional Medicaid long-term service support, but it's a benefit. We talked about the resources and the income. That's all rolled into them already being eligible for those Medicaid programs. So TSOA, we're looking at, again, the age limit. The income can be, right now, is $2,313. We've opened the door up with this number to far more people, a much larger group. Again, there's no participation, there's no cost for them, for their services, and then there's no estate recovery. Resources for an individual can be $50,000, can't say numbers today, $53,000, oh, you guys can read it. Yeah, $53,100. And then for a couple, it can be $108,647. That's those two numbers added up. And that doesn't include their home or one vehicle.
You said savings, would that also include pension plans or retirement plans
What's that?
as an asset? You said you talked about savings, but would an asset also include a retirement plan or a pension plan?
The financial worker at GCACH would determine if those are included or not. We just screen them initially by saying, do you have stocks, bonds, that type of thing. But if they have a retirement that they're getting monthly payments on, I don't know if they include the full retirement or just the monthly payments. So little details and, financial determination is huge, and whole departments at the SHS that do that. Thank goodness. So these are the steps. So, something can't just be a straight arrow. We have to have steps. So the first one is somebody who has gone through the step of being pre-screened. So we've asked about monthly income, we've asked about resources. We've also done what's called a NIFLOC, nursing facility level of care. So these folks still have to demonstrate a need for help in the home. So when I apply for Medicaid long-term service supports, I need to show that I need help in bathing, I need help with cognition, I might need help with mobility, toileting, that type of thing. So the presumptive eligibility piece includes that nursing facility level of care screening to show that they do need the help in the home. And they get, their benefit package is $250, and that's for a lifetime. Okay, I say that, now I'm wondering if I'm right. I'm pretty sure I'm right. If we had somebody there, I would look it up. Step 2 is based on also the presumptive eligibility, including that NIFLOC, and we would include the same type of screening we do for Family Caregiver Support Program. The platform is called TCARE, and we can also perform it depending on which program in our GCACH system. Do you guys know anything about GCACH or TCARE? Just platforms we use to administer the screening.
Is this $250 or $500 a month, or?
No, the $250 is one time. The $500 is once a year. And then the next step 3, not only do we do screening and the presumptive, which includes the NIFLOC, but we also do the assessment piece. And if it's a couple, the screenings and assessments are all based on the caregiver's thoughts and feelings. Now, if it's an individual, a person who doesn't have a caregiver, then it's based on what they're reporting to us on their care needs and their social situation, that type of thing. We're always going to try to find somebody who has a casual unpaid caregiver, because that's even additional support for that individual. So these are some of the benefit packages. It doesn't say this here, but step 3 has, right now today, the benefit package that the budget has to stay in monthly is $594. There's some little details around that. For a single person who doesn't have a casual unpaid caregiver, it is strictly the $594. If someone has that casual unpaid caregiver, it's actually, and I can't do math in my head, and $30,400 and some dollars, whatever $594 times 6 months is. Anybody have that number?
Under 336.
Yeah. So they get that first 6-month period. So say I'm a caregiver and I need to go out of town for a wedding for 2 weeks. Up front, the first month of my 6 months, I can have that service to help take care of my care receiver. But I have to stay within that budget for the rest of the 6 months. The budget doesn't refill until the start of the next 6 months. So part of it is this way to really, again, serving the caregivers and the care receivers in the right way at the right time. Because maybe that has been such a stress for that caregiver. Oh my gosh, I need to go to Texas to my son's wedding. And I have my husband who has dementia and I can't leave him alone. And yes, I have some family and friends that can fill in, but the bulk of it needs to be someone else. So it's just really wonderful the way that we can work within what that family needs. So these are some of the services we can provide in the benefit package. So, of course, there's caregiver assistance. So that can be a respite worker coming in to give the caregiver a break, to let the caregiver be able to go to lunch with her friends or go shopping. The things that are keeping him or her from being able to do those things because they can't leave their care receiver alone. Training and education. And we have nurses that we can, contract nurses that can go out and do teaching, help with training with caregiver skills, like safe, I've lost my word, safe transfers, yeah, I think that's it. Or skin, teaching them about skin observation, or nutrition, or helping them with medication management. Anything that's going to help them understand the disease process. Specialized medical equipment. So this might be incontinence supplies. This could be a walker. Now again, we're going to see if it's covered through their insurance, or if we can get it from Knights of Columbus, or whatever our community resources are. But if those are exhausted, then we're going to help pay for that through the program. Meals on Wheels, that's another service we can cover. We don't have a transportation provider here in Franklin County that we've contracted with, but they do have one in Yakima County. So, and just a heads up, all these services are available through Initiative 2, but it doesn't mean we have them in every community. We have adult day services here, but they don't have any in Clarkston. So yes, it's in the benefit package, but if we don't have a contractor to provide it, it's just not a service we can authorize. Therapies, so this would again be any type of support that that caregiver would need to help her continue, or him to continue to provide that care. And then personal assistance, this again is providing some of that physical care to the person who needs care or to the home. Although we don't chop wood, we don't change sprinklers. You know, it's limited to certain services within the home.
Leanne, can you talk a little bit about those last two categories in terms of some examples?
Now, I'm struggling with an example for health maintenance and therapy. Like physical therapies or occupational therapies, counseling, that type of thing. Counseling comes to mind because we have that. And then under the personal care assistance, this is for a family that has a casual and paid caregiver can have respite or housekeeping and errands. A person that's an individual, and it's not both, it's one or the other. A person that's an individual can only have personal care services. So they wouldn't need respite because they don't have a caregiver that needs a break, right? So this is talking about what our agency does, specifically to Southeast Washington Aging Long-Term Care. So we were the very first in the whole entire state to do an authorization for this program, Initiative 2. We continue to have the largest numbers. Now, we all know King County is huge by population, but it depended on how that AAA was choosing to move forward with Initiative 2. And we were in the forefront, and I just might as well call it out. Corey was in the forefront, and Lori, our director. We prepared previously and integrated some of the same practices we were going to need for Initiative 2. So we were ready, which is why we were able to do the first authorization in September of 2017. So a lot of this, we need to continue that momentum, right? And so we're continuing to work with our partnerships And we have great teams of staff that have taken and embraced this program, willingness to go to training, willingness to make mistakes and learn from them and move forward. We did have a lot of trial and error at the beginning. With a new program, as you may have experienced with Initiative 1, you think you know what to do to move forward, and then you find out that you needed to take a turn instead. And that's the same experience we've had.
So Leanne, are you going to talk about, the outcomes so that with this program, how the outcomes for the patient have been affected? Are you going to talk about the outcomes of the patient? So you've got this program in place for the caregivers, but you would think that there's a commensurate positive outcome for the patients that are being taken care of.
So what I would say with that measurement would be not just a satisfaction survey, but would be numbers of how many didn't go on to Medicaid. They went on later than sooner, right? So I don't have those kind of figures. I'm guessing that the state does. And I will, if you write that question down, I will take that back to get you the whole group of that information. Thank you.
Great.
That does it. Oh, no. Okay. Maybe I've got my slides in the wrong order. I just don't have the slide. Okay, we continue to serve new individuals every month to bring the average to 33 new people a month. Our goal is 50. Yakima, our office Yakima continues to have the highest number. So their recruiting numbers are higher than Benton Franklin County. And of course, we're looking to them to emulate what they're doing so we can bring our local numbers up as well. Amazingly enough, Sullivan County has brought on for their population a huge amount. And how I take that is that I'm not saying we don't have the need and Yakima doesn't have the need, but they're a smaller community. It just may have a different way of coming to the program. So, and just to give you some perspective, even with the new Initiative 2, we still are able to grow our family caregiver support program. 117% growth just in 2018. So let's see. Oh, there we go. So remember we talked about how hard it is for caregivers to self-identify as a caregiver. So one of the ways that we try to reach out and get our foot in the door, or at least start that dialogue, build a foundation, is by contacting our large employers in our larger counties to go through their HR department or their wellness program to get our information out there. We also, if you've gone to the movies lately, you might have seen in some of the theaters, we have, it flashes up and it shows somebody, the one I've seen is an elderly gentleman, and he says, I think it says, I remind my wife to take her pills. And then it says, we call it caregiving. So that's one of the other ways that we do outreach. We also have a TV commercial going right now. And I believe we're going to see that TV commercial now.
They've been caring for you your whole life. Now it's your turn to care for them. Family caregiving involves spouses, children, parents, neighbors, and others. In Southeast Washington, the Family Caregiver Support Program helps hundreds of families cope with the day-to-day tasks of providing care. When your role changes, we are here to help.
Nice.
Has anybody seen this commercial on TV? It's on one station, I can't remember which one it is.
So Leanne, I have a question for you. Have you worked with 211 to post information about the services that you're providing?
You know, we have a really good relationship with Joyce Newsom at 211, and when people have a call in about social service programs, they just instantly just refer them to us. And then we're able to hear that person's story, because not all programs fit all situations. And so the first thing we're going to do is hear that story and then tell them about what their options are. And so it might be that they're telling us that their loved one has $6,000 a month income. Well, I'm not going to talk to them about Initiative 2. I'm going to talk to them about community resources and other ways that they can provide that support in their home. So it's individualized. That's we use an evidence-based program, or call it program, options, person-centered options counseling. So we want to make sure that people know what their options are. I do a lot of community outreach, trying to get the word out. Again, it's not always specific to Initiative 2.
Okay. And I know that their eligibility is complicated, but have you done any outreach to the Yakima Nation?
I would, that would probably be answered by the Yakima office, and they actually have a AAA there, and they are doing the program. They come to some of the trainings that I do for, specifically for Initiative 2 when I'm in the Yakima area.
I had a question.
Yes.
On the scoring documents that you mentioned, the Keep Here and Get Here, are there questions that relate to the social determinants, like housing or food insecurity, anything, transportation issues? So is it strictly a scoring or screening document that addresses direct care needs, or does it include social determinants?
So when we screen the caregiver, we're asking about their thoughts and feelings, and then we do ask them how much time you spend with meal prep. We don't go further into, are you able to get groceries?
Or having difficulty in transporting this person, the one you're caring for, to their appointment?
We're asking if they provide the transportation, and then that usually leads to a dialogue about, because we're wanting to reduce caregiver burden. So we're saying, well, do you have dial-a-ride? Is that something that would work for your loved one? Would that be something that would help reduce your stress and strain by having someone else help with that transportation? For the people that are the TSOA individuals that don't have that casual unpaid caregiver, we are asking a little more in-depth questions, things about their feelings, if they've been sad, that type of thing, and then if they plan to move, you know, trying to then have a dialogue with them about those needs that they have. We don't have specific questions that say, are you able to get food? We don't have specific questions. These are all dialogues that my expectation of the case manager would delve into during their time we get to know them. This isn't just I'm going to come to your house and do an assessment. This is looking at the whole person, and we practice a holistic approach. Any other questions? So the main thing is in your area that you work and live, refer people to your local Aging and Disability Resource Center. And the flyers I passed out, it has our local number for the Kennewick office. All right, well, thank you for your time today.
Leanne, thank you so much for coming and visiting with us today. So in listening to that presentation, what stands out to you as being significant about Initiative 2 and the services that are being provided here? Does anything stand out to individuals that might be an aha or something noteworthy? Nothing? So this is familiar to everybody? We're all comfortable with this? Sherry, I'm looking at you because I know you've gone through this not so far ago.
I just like that they're adding more programs and they don't have to put all the money down. I'd like to learn more about it, but I have to.
Okay. All right. So next up, we have Jacob Avery, who is from AmeriGroup, and we're going into Initiative 3 now, which relates to foundational community supports. We appreciate Jacob coming down and visiting with us today.
Sure.
Thanks a lot, Buzz. So we talked about Initiative 1 and Initiative 2, and now I'm going to talk to you about Initiative 3. And for the folks working on Initiative 3, we call it Foundational Community Supports, or FCS. Initiative 3 is a way to use Medicaid funding to address social determinants. Basically, the two services are supported employment and supportive housing. And this is a way to use Medicaid funding for things that are really going to make a big difference in people's lives that generally are not paid for through Medicaid funding. For some people who are experiencing homelessness, we will pay for quite a few crisis services. We will pay for behavioral health services, but we will not pay for a service that might help them find a home. As you may know, there's over 20,000 homeless individuals, people experiencing homelessness in the state of Washington. And this program aims to see if at least Medicaid can help change some of the health conditions by addressing some of the things that are actually happening in their lives. So I'm going to talk about the two services a little bit. One is supportive housing. This is a service that helps you find a home and stay there. What this really pays for are the services associated with supportive housing. So this is a housing specialist that will help you complete a housing assessment, apply for an apartment or a supportive housing unit. Once you get housed, they will help you maintain housing. There are a lot of folks enrolled in this program who are either in permanent supportive housing or who have some housing when enrolled, but have had serious difficulties with housing stability, either because of a medical, behavioral health condition or social conditions happening in their lives. Really, there's a lot of things that fall under supportive housing services that can be built for. This can include care coordination, honestly. This can include things like teaming up with their mental health team, other folks in their care team. And one of the nice things about the benefit is that really it can encompass a lot. That said, we don't want this to be a standalone benefit. The supportive housing specialist should not be doing all the care. Ideally, this program works best if they're receiving medical services, behavioral health services, long-term care, or whatever else they need. What this program isn't is a subsidy for room and board. It doesn't pay for rent. It doesn't pay for moving costs. Right now, it's not for all Medicaid eligible people. You have to meet a health needs-based criteria and have a risk factor in order to qualify for this program. So it will unfortunately not be a possibility for everyone experiencing homelessness, but I do think this is a great start to helping some of those folks. I know the long-term goal of this program is to help Medicaid pay for some of these services in the hope that funding can be moved around where funding that was previously used to pay for services can be used to pay for things like capital housing, like rent supports, things that Medicaid at this point in our history will not be willing to pay for. Thank you. There we go. The other benefits supported employment. I believe over 50% of the folks on Medicaid would actually like to work. That was, I cannot remember where I got that stat from, but right now, however, a lot of folks who are on Medicaid are worried about losing their benefits. If you make over a certain amount and you're on expansion Medicaid, you will lose your Medicaid. If you're receiving APD or Social Security, you may be worried that you're going to stop getting your only source of income. Supported employment services are a way to pay for some of the services to help find and maintain employment. So this is both for folks who are doing a job search. Most of us, maybe we got our first job through someone we knew, through a friend telling us where to apply, or at a low entry job. I know I did. And there are some folks who have not worked for a really long time. They don't have any connections of people that work. They may not, because of a certain disability they're experiencing, they may need some supports to maintain that employment. This service of SES pays for that. It is a distinct service from DVR, Division of Vocational Rehab, and Supported Employment Services through the Developmental Disability Administration. This service is not meant to overlap with them. Medicaid is always the payer of last resort, but there are a lot of folks who are currently on order selection for DVR, so they can immediately get DVR job search services, who would qualify for this program. It can be very useful for them. Other folks who may have worked with DVR before but can't anymore and still need job retention services also can use this service. It's not a subsidy for wages, and again, you need a health needs-based criteria and a risk factor to qualify for it, so not everyone on Medicaid is going to qualify. So I'm here from AmeriGroup. We are the third-party administrator for this program during the pilot program. Our role is we provide administrative services. So we do the contracting, credentialing for the provider network. We do claims payment, service authorization, and part of our role is to provide a sustainability plan when this pilot program ends. This will end like all the Healthier Washington on December 31st, 2021. And hopefully, I'm hoping anyway, this will be a permanent Medicaid benefit after that if we measure outcomes and we see quality improvements in people's health. I believe it will be. We're the third-party administrator because our boss is the healthcare authority, basically, and this is also a project. We are partnering with DBHR and ALTSA. And it was decided at some point in 2017 there would be a third-party administrator. There was a bid, and AmeriGroup won. And basically our role is to set up all the administrative services to make this program fly. So I wanted to talk to you a little bit more about eligibility. I talked about a health needs-based criteria and a risk factor. I'll go into those a little bit. One, you need to qualify for Medicaid. This is a Medicaid program, so of course you need to qualify for Medicaid. For supportive housing, you need to be 18 years old. For some of our family shelters, this means that the parents can be enrolled, but the children cannot. For supported employment, you can be at least 16 years. You can be 16 years old or older, which is great. I think 3 or 4% of our enrollees for supported employment are 16 or 17 now. That's really gone up lately because we've been working with some youth programs, and that's really great to see. You also need to. Question?
Do you have the standard definitions for supportive housing, and so could you describe what supportive housing means?
Yeah, so it's a very detailed definition of many lines, but I can give you the basic rundown. Basically, it's the services associated with finding and maintaining housing. So it's things like filling out a housing application, assisting folks in getting their prescription that would allow them to apply for an application. Some of these services, in my opinion, seem a little like case management, but I've been told by the healthcare authority these are not case management services, they are supportive housing. The goals all need to be based on finding and maintaining housing, if it's a supportive housing. So there are multiple lines of what this entails. My feeling is there is a very broad definition of what's allowed. But we do want to make sure all the documentation the goal is finding or maintaining housing.
Okay, thank you.
You need to have a medical necessity to qualify for this program. For both the services, they're very similar. You need to have a mental health or substance use diagnosis. That's one way you can do it. If you are receiving in-home support services, if you need help with 3 or more ADLs or hands-on help with 1 or more ADL, that'll do it. If you're on HEN or ABD, you will pretty much automatically qualify for our supported employment program. You also need to meet a specific risk factor for both the programs. They're a little different. I'll show you what those are next, and I can answer detailed questions about this if you like. We might get a little into the weeds if we go over this in detail, but I can go over them quickly. For supportive housing, for risk factor, we're looking for frequent or lengthy homelessness. Basically, what this boils down to is the HUD definition of chronic homelessness. As we all know, there are a lot of folks who are experiencing fairly serious homelessness who don't qualify for the HUD definition of chronic homelessness. Luckily, they only need to meet one of these, so a lot of times, even if they don't meet this definition, they will qualify for our program. Another risk factor for supportive housing is 2 or more, frequent or lengthy, I should say, institutional contacts. Frequent is 2 in the last year. That can include hospitalization. It can include incarceration. It can include an ER visit. And lengthy is 90 days or more. So if you were in the hospital for 90 days or more, you would meet that risk factor. Frequent turnover of in-home caregivers means you've had 3 or more in-home caregivers in the last year. The state has a predictive health score, help to predict your chance of hospitalization. That's called PRISM. If that score is 1.5 or more, you also meet the risk factor. One of the things about PRISM is most of our contracted provider agencies don't actually have access to it. And so it makes it difficult for them to know if someone's actually going to qualify for this. We will always check it, but it's one of the interesting things about the program in that this usually isn't visible to most of our providers. For supported employment, we're looking for if they qualify for ABD or HEN, if they've had multiple inpatient or residential sub-treatment in the past 2 years, or if they have difficulty maintaining employment due to age, mental impairment, traumatic brain injury. This usually goes along with receiving assistance with ADLs, or if they require ongoing treatment for mental health or substance use disorder. Here's kind of a roadmap of where we've been and where we're going. This was a 5-year program, but CMS didn't give us a planning year. So the first year, we were not able to actually provide services. The FCS protocol was approved by CMS in November 2017. That gave us 1 month of contract. So we had kind of a soft launch in early 2018. We've been building the provider network and trying to automate all the services ever since then. And we actually have a pretty robust provider network now. We're building it all over the state. I know some folks in this room are already contracted as an agency. If you're with an agency, we require a tax ID, a Medicaid ID, an MPI, and a business license. And there's also, you need some history providing supportive housing or supportive employment services. But a lot of the providers we've contracted with, their agencies have never billed Medicaid before because they are traditional supportive housing or supportive employment services. If that is the case, we can walk you through the process of getting an MPI and a Medicaid number. And I think it's really exciting that some of these folks are able to bill for services with Medicaid that they really weren't before. And this is our provider network. And these are, no, it's not actually. This is actually enrollees. We have over 4,000 enrollees now. It's actually a little higher than this. And you'll see Greater Columbia up there. You're at 596. As you can see, it's actually pretty evenly distributed between supported employment, supported housing. That's not completely typical. We actually started off with much more supported employment. We anticipated when we started this program that 2/3 of the enrollment would be supportive housing, and it was almost exactly the opposite. As time has gone on, it's actually evening out. So our majority is still supported employment, but we're getting more and more supportive housing enrollees. As you can see, there's very good enrollment for Greater Columbia. We have great participation. I think it's about an 8 for enrollment right now. And these are provider network sites. These are not individual agencies. They're sites across the state. I think there are either 99 or 100 individual providers. See Greater Columbia up there, there are 32 total sites. Most of those are actually both supported employment and supported housing. Honestly, not all those are actually actively enrolling clients, but we have a number of local agencies that are. And here they are. So this is a list of all the agencies we have contracted for the Greater Columbia area. I know some are in this room, and these are the services they're providing right now. We've kind of gone with a no wrong door approach to this program. So anyone can refer a potential enrollee. We have a referral form on our website. We've had family members refer. We've had providers that are not contracted with us refer. We've had individuals call our program directly and ask to be linked with a provider. I will say probably the easiest way is to directly call the provider. That's directly call the agency. I'm using insurance talk when I say provider. Simply because it cuts out the middleman. We have a little delay when you refer through us, but that said, you can definitely fax us a referral sheet or call us directly. We also have a quick reference guide on our website that can give you a good idea whether someone might qualify for the program. That'll go into a little more detail on those risk factors and needs-based criteria. We only use 3 billing codes, and people always ask me about this, so I wanted to talk to you about the rates of reimbursement. We always authorize services for periods of 180 days, or about 6 months. For support for both services, actually, we authorize about 30 hours for support employment. It's actually exactly 30 hours. And we bill in units of 15 minutes. Each unit pays at a rate of $25. For supportive housing, it bills a little differently. It bills in per diem units, so you can only bill 1 a day. And we recommend 60 minutes with an individual enrollee, and it pays at a rate of $105. You can continue to reauthorize folks for services once they're enrolled in the program. Even if when they entered the program, they were chronically homeless and they no longer are because you've helped them find housing, we can re-enroll them. We can use that risk factor to say, well, this was your initial risk factor, we can re-enroll you in the program. This is assuming they still need services and still want services. This is a little bit more about reimbursement rates. I also wanted to talk about the exception of the rule process. So we initially authorized 30 hours, but some people need more. We have a process where you can request more units if you need it. And this is something that was created just to see how this is financially viable for certain organizations. We recommend a case, support them special at that time, and you're using all their units, that 126,000. For support. That is a recommended amount, I think, for both of these programs. One of the nice things about FCS is, I told you before that it used for job search. We can't use FCS for a job search, but there's a lot of things that DVR offers that FCS does not. If they're helping you with work equipment, if they're helping you with modifications, so you can keep and find a job, DVR can continue to help you with that. Also, one of the ways this pairs really well with DVR is if you have been exited from DVR after finding a job, but you still need ongoing support, sometimes DVR will actually call us and make sure when that contract ends that they are able to get FCS services. This program uses a couple evidence-based fidelity models for support employment. It uses the individual placement and support model. Some of the criteria for that is open to anyone who wants work. It focuses on competitive employment, systematic job development. It prioritizes a rapid job search, and client preferences guide job decisions. Now, this is part of our contract, but we know all of our provider agencies are maybe not completely familiar with this model. So this is a gradual process of bringing this information and educating our provider network on this. One of the interesting things about this program is we share, we're the third-party administrator, but we share a lot of duties with ALSA and DBHR. DBHR, one of their roles is actually training in these fidelity models. Again, there is no punishment if you do not pass fidelity, and right now our fidelity, we're doing fidelity reviews for individual agencies, and these are opportunities to learn where you can improve. No one is going to lose their contract because they don't meet the fidelity model at this time, or any time in the pilot, I should say. The supportive housing program, there's another fidelity model. This is the permanent supportive housing model with SAM HSA. And again, this is a choice of housing, separation of housing and services, housing integration, decent, safe, and affordable housing. Obviously, some of these things are dependent on the market, and there may not be decent, safe, and affordable housing in your area. One of the issues with this fidelity model, what this fidelity model says is that's a goal, and that's something we should try to offer. It may not be immediately available, obviously. So I also wanted to talk to you about, we are continually measuring outcomes for this program, and we don't actually have outcomes right now on how this has affected housing or employment. We should have those within 6 months, and I would love to share those with you. We do have demographic outcomes right now. One of the things that's interesting about this program, I think it's 97% of the individuals enrolled have had some mental health diagnosis in the past 24 months. 72%, I believe, had co-occurring diagnoses in the past 24 months. However, only I think 27% have actually received both SUD and substance use and mental health treatment in the past 24 months. So a large majority of folks enrolled in this program have some sort of behavioral health diagnosis or have had one at some time. Most of them are not receiving co-occurring treatment.
They don't have to receive treatment in order to be on the service, because I had potential providers that we're working with ask me that question today, or say that he thought that might be the issue for them.
That's a really good point. Yeah, so there are no other criteria for receiving this service. You can receive support employment services or supportive housing services whether or not you receive mental health services. That said, if someone has serious mental health issues, obviously it's going to be much better for them to receive mental health services at the same time. And we recommend that, if necessary, you bring in their mental health team and try to get them those additional supports. But that said, if they say no, this is about client choice and immediate employment. It just may limit their options if they're not able to, manage mental health symptoms. Is there a question up there? Okay. Right now, the enrollment's about 50-50 in terms of male and female. Initially, we had a little more male enrollment, but I think that's around even right now. I think 70% of enrollment is non-Hispanic white right now, and I believe Latino Hispanic is the next largest group. Also, I think about 17% of our current enrollees have had a care assessment in the past 24 months. For those of you who don't know, a care assessment is what Housing and Community Services does when folks may need in-home supports or an adult family home or some other sort of aging and long-term care services. For those who are enrolled in the supportive housing program, around 23% are chronically homeless. And I think about 32% also qualify for the HEN program. This program also pairs quite well for folks who are on HEN. I have worked with a number of individuals. I was a social worker working in a clinical role as a case manager in my past life, who are receiving HEN, but because of disabilities or various things that are going on in their life, are unable to find housing despite the fact that they have a funding source. And for folks like that, the supportive housing program can be great because someone can help them find housing where they can actually use their HEN, help them move in, and then help give them supports they need to stay in that housing. As I said before, if you're on HEN, you also qualify for the supported employment program. So that's a great opportunity if you're interested in employment. So Aging and Long-Term Support Administration is one of our partners. Their goal, they actually refer a lot of their clients to this program, which is great. And they also help support our providers, particularly those who are working with aging and long-term care clients. They go by region, and for Eastern Washington, anything east of the Cascades, for supportive housing, their representative is Ian Harpole. For supportive employment, it's Jim Bischoff. For agencies that are looking for more enrollees, they are often able to refer them to you. I don't know what to do. Thank you. For technical assistance is done by Department of Behavioral Health and Recovery. And for Eastern Washington, for supportive housing, that's done by Amanda Pauley. She gets around all of Eastern Washington. And for supported employment, that's Don Miller. They do trainings, both formal and informal, with certain agencies and some open trainings as well. If you're interested in the program, particularly the programmatic aspects, how to run a supportive housing program, something about the fidelity models, what we've seen works best, they're great people to contact. And these are our websites. This is our provider website. It has a provider manual on it, a quick reference guide for folks who might qualify for the program. Basically, we authorize services when people send us an assessment form. It's 6 or 7 pages long for supportive housing. It's 5 pages long for supported employment. You can look at those forms if you want, if you go to our website. We also have a provider map. They've just replaced that, so don't use that one because it's not going to be complete. But it will give you a little bit of an idea of our provider network. Our provider resource guide, that's actually at the Healthcare Authority website. That's very useful. I recommend that one as well. We also have a client-facing website, which tells a little more about the program. And this is our team. I'm one of the FCS managers. My name is Jacob Avery. Our director is Tori Camden. And this is my contact information. I can talk a little more about the program, but I wanted to see if there's any questions so far. Yes?
I actually have a comment because
Sure.
I attend the advisory council quarterly meetings, and an issue that has come up at the last 2 meetings is that there's a contractual requirement for folks who are actually providing these services to turn in outcome reports. And only about 20% of the reports are being sent into AmeriGroup right now. And so if we want to actually see this program become permanent, those outcome reports need to be turned in. Totally fine to turn them in late. AmeriGroup just needs the information, and we need to be able to track this and prove the value. So I just want to note for folks in the room, please turn in your outcome reports. There may be a stick coming later if that continues to be an issue.
That's very true, and thank you very much. Yeah, we absolutely need those outcome reports. Yeah. And it has improved vastly already when we've been a little pushier about it.
Well, who the agencies are, I guess, on those reports, because I see I collect looking up the agencies to see which agencies cover, and we have some charities here it comes up, but we don't. We have that program in Wenatchee, but we don't do it.
That's
I'm wondering if you're
yeah.
looking for reports too from places that, like, we're never gonna.
Yeah, if you don't have any enrollment, you don't have to send us a report. Yeah, please don't.
Mine is where to go. We're up there, and I've emailed where you see our name, but we don't provide that here, only in Wenatchee. So
Yeah, we should fix that. Let me see what I can do about that when I get back to the office, because, yeah, if you're not providing the service there, people probably shouldn't be calling you, so, sorry about that.
I appreciate the high level look at that program. Kind of in the weeds part of things. There's a homeless shelter in Waddle, one in Price City, and one in Yakima. Do you have a provider who has with connecting with each of those shelters to help their staff who are volunteers who are working on the same issue on a shelter?
I would say, honestly, probably we've done this a little piecemeal. This is, I mean, the great thing about being here is this is the entire Greater Columbia region. Sometimes things happen more on a county level, so we've addressed the counties, and sometimes the county staff is more motivated to work with us, and sometimes less. So sometimes we've worked it on the individual provider agency level. Obviously, our goal is to work with local administrative, often with the counties or the ACHs to make this happen. We found when we've done that, we've been much more successful. We've had much better buy-in from local agencies. And we can also make this program work with the tools that already exist, coordinated entry, local shelters, tools for homeless and individuals who need supported employment that are already in place. This program's not meant to replace any of those. It's meant to work with them.
So can I just be really specific?
Yeah.
If I'm at the homeless shelter located in Pasco, and I'm working with homeless individuals, and I know that there are two case managers working on the issue of housing, how do we know who is the provider from this program specifically to act with, this community?
Yeah, right now, if they don't tell you, you don't know. One of the issues with this being a Medicaid program is that these are considered Medicaid services, so they're subject to HIPAA. If you have Provider 1 access, you're looking at Medicaid eligibility. There's actually a flag that tells you whether they're enrolled in the program or not, but it won't tell you what agency they're working with. And it also won't tell you if they're enrolled in the program, but they're not actually working with someone because they haven't talked to them in a couple months. The easiest way is to ask them, and hopefully they'll know. Definitely if they are enrolled but don't know who they're working with, you can call us with them or get a release of information, and we can let you know. Right now, there's no easy way to tell, unfortunately. And that's one of the challenges I think about this program is that because it's a Medicaid service, it doesn't, at this point, completely integrate with all the homeless resources we have in the state right now. I'm hoping that will be more the case over time. Well, if there's no more questions, thank you. I appreciate it. Jacob, thank you so much for coming down here today and presenting to us. I'm wondering, we have one more presentation we're going to go through, but before we go forward, I know some of the individuals who are tied to the FCS provider network are here in the audience, and I'm wondering, do they have anything to say about enrollee experiences with this program? Even though it's relatively recent, have there been any stories about from Catholic Charities or YNHS? Have you had any patient experience stories with this program?
I presented last month, and I would just say anything we can do to support it. We both supported housing and supported employment. we have lots of people at work. I think, out of we've enrolled over 100 people in supported employment. I think to Jacob's comment, I think the reason, that there are fewer as anticipated in supportive housing is just, it's hard to find housing. And we've been talking about that for a long time, but I think that's part of the explanation for that.
Right.
You know, in terms of, there's a list on, I can't remember where it's at, but under tenancy supports, on the things that, that qualify for supportive housing that really just are about helping people maintain stable housing. And that's been a big piece of what our staff do. And in terms of Susan, we spend a lot of time with the mission, but a big part of getting people enrolled is maintaining contact with them. And then people that stay at the mission are fairly transit, not from town, but just from that location. And so until you're ready to help them get into housing, it's really hard and maybe not terribly meaningful to enroll them in supportive housing until you think you have a lead on housing. Doesn't mean we're not contacting them, it's a matter of enrolling in the program. But we have quite a few people employed. I think of the last outcomes report that we submitted. We had to be reminded of the importance of those. I think, you know, we're seeing that we're getting people employed, and it's a day-to-day or a couple times a week that our employment specialists go out and actually spend time with them, and that matters. To feel that they have that support, that they go into workplace, and some of the important employers, and Yakima, they're agricultural, you know, that they can also call our employment specialists. I think it's really making a difference. So, you know, we're there for them. If there's anything that they need for us to be able to help the clients and this program, I think it's an incredibly valuable program.
That's great to hear. So we've been having more success with employment than with the housing piece, simply because of the capacity issue, and particularly in Yakima. I think everybody's aware that there's a big need for that.
Yeah, I don't think it's just Yakima. I mean, I think everywhere.
Wes, I think what's cool about it too is that the case management, or they don't call case management, like the employment piece of it, they match that person with the type of job that they would succeed in. So maybe if they have autism, they get them in a position that they would thrive in autism instead of just putting them into a job where they can't succeed. So I think that's really important to keep.
That's great. So good matching of a position with what the individual skills and capabilities are. Any other comments relating to that discussion? That's always really interesting. I've heard this before, and I always learn something from it. And speaking of supportive housing, the Greater Columbia has an initiative underway where we have a supportive housing task force that's geared toward and steering toward a supportive housing complex here in the Tri-Cities. And to talk more about that, we're going to ask Carol to come up and give a brief presentation.
Thanks, Wes. So I have drunk the Kool-Aid. And the Kool-Aid is housing first, and it really is the model as we're talking about. It's meaningless to have a lot of services in your community unless you can get people housed. And so even way back in the day when I was managing the Benton Franklin Community Health Alliance, we recognized the need for supportive housing in the Tri-Cities, and we've tried to work with Benton Franklin Human Services and just couldn't get anything going. Recently, though, that need was exacerbated by the fact that with the transition of Lourdes being purchased by RCCH and then LifePoint pulled out of their supportive housing units. And so it's really created more of a crisis situation in the Tri-Cities. So I was approached by Lourdes to, you know, is there anything that Greater Columbia can do? And we called on all of our partners, including our board president, Rhonda Huff. We called upon Rod McCann of Catholic Charities Diocese in Spokane to put on a housing summit so that we could gather the partners to see what level of interest was there to bring together a group of people to address this problem. And lo and behold, on March 19th, we had over 91 people show up. And I was so appreciative of the Pasco and the Kennewick Fire and police departments that showed up, the support services, mental health, behavioral health. They all came together and we took advantage
of the knowledge that Rhonda and Rob shared about the success stories that they've had in Spokane and Yakima. So I'm going to talk a little bit about, you know, obviously why we need supportive housing in the Tri-Cities is we have so few units. And if you can't get people into supportive housing, then they're primarily homeless. And we know that we have an increasing number of homeless people in the Tri-Cities. You can see them every day. I don't think 20 years ago it used to be an issue, but it's becoming very obvious that we have a problem in the Tri-Cities. So how do you solve that? Well, we were presented with a couple of different models. And because Catholic Charities in Spokane has done so many of these and they have acted as developer, we were really grateful for them to come down and show us the model that they used, and we'll talk a little bit about Rhonda's model. It took them a little bit longer, but we got to go through their facility recently, and it's just absolutely amazing. It's just transformative. So we all know, according to Maslow's hierarchy need, that if you cannot satisfy the physiological needs of human beings, you know, the primary needs of, you know, food, water, shelter, that trying to address their diabetes is meaningless. I think we learned that when we were trying to address diabetes from the Tri-Cities, from the Ben Franklin Community Health Alliance, is that when you cannot satisfy people's basic needs, it's hard to go upstream. It's hard for them to care about taking their diabetes medication when they are on the street just trying to survive. So we know that it's a fundamental issue for all human beings to have food and shelter. We also looked at some of our data. We had a advantage to look at the Matthew Kidders report that Catholic Charities put together for the purposes of looking at the Tri-Cities as a place for supportive housing. And they estimated about 845 literally homeless people in the Tri-Cities. And we know at least a quarter of those need supportive housing. So that led them to believe that a facility in the Tri-Cities was feasible. We also know that homeless people, people that are very high risk, also drive utilization rates of our emergency departments, our jails, our hospitals, inpatient beds. So financially, it is a very intensive use of services from a very small population, and these people are at high risk. And that's not good for them. It's not good for the hospitals. We already know that. We've already seen the statistics on our emergency department utilization. And I think the proof was in the pudding after this meeting on the 19th is that literally the Benton and Franklin County fire and police departments were hovering around Rob McCann. I think they were hungry to have this kind of information and to think about the possibilities of having the opportunity to help these people as opposed to throwing them in jail, now that this could offer another alternative. So the cost savings are tremendous. We did a little bit of research for an average day stay. Maybe Larry, you could help us out with this. In Cadillac, we found about $2,400 a day compared to $85 a night in the jail. Compared to, it's free at the Union Gospel Mission, we found out from Susan this morning. But even having supportive housing, I don't know, Rhonda, do people pay to stay at the RDH?
Yeah.
Okay.
Well, just like our rules are just like in housing as opposed to shelter or a respite program.
Okay.
But in housing programs, typically, if they have income, they pay 30% of their income. If they have no income, they don't pay anything.
Okay, so what Rhonda said is that typically in their program, residents would spend 30% of their income to support their housing needs. That's still probably way lower than a night in jail. And plus you get supportive services. The other concern I think that we were able to address is that a lot of local elected officials are very shy of creative supportive housing programs, as Rhonda knows. Spokane actually did a survey to show that 85% of the people that were in their shelters actually lived within Spokane County or within 75 miles of Spokane. So that helps defray, I think, any concerns of local elected officials over they're just going to come in by the busloads. Actually, these people are within our community, and we feel a moral responsibility of taking care of those individuals that are within our community. And it works. It was wonderful to be able to go through the RDH Center in Yakima and to see residents there that they were happy. They, you know, they just mentally they looked a lot, you know, more happy. I just think that it's just it's just wonderful when you can get people on a path to success, but you really do have to start with the housing first. We have put together on this flyer that's in your report, we've got the definitions of chronically homeless and supportive housing. The initiative that we're really looking for in the Tri-Cities, though, is for at-risk individuals that are chronically homeless. There are lots of needs for affordable housing, we know that, but we are really concentrating on these high-risk individuals, and I think that that's why we have attracted the partners that you can see on the right-hand side. Cadillac is very interested in this project, as is Lords, with Domestic Violence Services, Community Action Connections, Catholic Charities, Blue Mountain Action Council, the Veterans Group. I spoke to Modern Family just the other day, and they're very interested. And so the opportunity, I think, has come in front of us. It's landed in front of us. Catholic Charities has agreed to be the developer of this project. So we are starting to work now with the city of Pasco to find a site. Rob McCann was down here on Monday. He located some sites, and those sites will come back to the committee. The committee is totally open to anybody who wants to attend these meetings. Eventually, what we would like to do, though, is to bridge this committee to the Continuum of Care. The Continuum of Care is a group under the Benton Franklin Department of Human Services, and they have a strong interest in taking this over. We're just trying to get it started. They've always had a dream of having the kinds of partnerships that we've been able to reach out to because of our large distribution list, I think, of Greater Columbia. And so it's our intent that we would transition this committee over to the Human Services Department. But until such time, Greater Columbia is going to help facilitate, you know, the development of this project. And hopefully it won't take us 6 years to build, but it might take us several years to build. We were fortunate with these 91 individuals who sent a follow-up survey as, you know, what would you be willing to do? I think it's one of the biggest challenges is that, you know, it's great to talk about supportive housing, but when push comes to shove and you have to get those zoning rezones from the cities, or you have to go in front of the neighborhood, you know that you need support. And so we surveyed our population to say, what would you be willing to do? Would you be willing to talk to an elected official, or a planning commissioner, or a county commissioner, or your local businesses? And so we have a cadre of people that have signed up to help support these initiatives when they come out, because it's really important when you're in front of the city council that you've got more people speaking in favor of something than against it, because, you know, most of the people that come would be against a project. So we feel really comfortable, and I think Rob is very happy that they would have that kind of support in the Tri-Cities for this kind of a project. There was one other thing that I was going to say. So we talk about, you know, some of the statistics related to the costs and the benefits to individuals, and on the back that we've kind of articulated those advantages. So what we've tried to do is to create a flyer so that as people go out and they talk to individuals or communities, that they have some talking points. And you can read about all of those. But I did want to highlight the Yakima Neighborhood Health Services and to thank them so much for their leadership. We didn't find out until we went up to Yakima that RDH actually stood for Rhonda Diane Huff. And this facility was built in honor of all of the hard work that she has done across our region and across the state and really the nation. She's a national leader in housing. I think we're all drinking the Kool-Aid, and hopefully we can all be as knowledgeable about as Rhonda is at the end of this journey about how to build supportive housing in our community. So thank you, Rhonda, for your amazing leadership.
Carol, thank you very much. From the beginning of this process, the Medicaid Transformation Project, it's been very clear to not only this ACH, but the other ACHs, the link between the social determinants and health outcomes. And the research has shown over and over again that social determinants have a greater degree to the variability of mortality outcomes than even the healthcare system. In fact, it's much more significant. So we are not required, I have to be honest, to pursue this path, but we know it's important. Personally, I admire Rhonda for the work that she did in Yakima, and I admire the work that Carol is doing. Carol brings in a lot of public administration experience on Richland City Council, which has been really helpful in understanding the rules, the regulations, the permitting process. But I know deep down that personally and spiritually, this helps fulfill her personal mission. So I'm just very great respect for that. So as we talked about earlier, there will be no Leadership Council meeting in June. We will be meeting in July, and at that point, we will be talking about workforce. And that said, if you have some ideas about workforce or people you want to hear, feel free to message Lauren, and we'll take that into consideration as we generate our list of speakers and our agenda. And with that, we're adjourned. Thank you.